So as I was saying, so thank you for the opportunity to discuss a little bit further the research we are doing in Australia and that I presented at ESMO this year. So as you can see, this is international collaboration trying to answer the question of anti-PD1 monotherapy in monotherapy or in combination with Ipilimumab after BRAF and MEK inhibitors. So the main the background and rationale to this project is because we know that in the Checkmate 067, where patients were randomized at first line to PD1 monotherapy, Ipi-PD1 or to Ipi upfront, we see that the combination of Ipi-PD1 was numerically higher, like in terms of objective response rate, progression-free survival, and overall survival compared to PD1 monotherapy. But that advantage was significant when we talk about BRAF-mutant patients. So that was first line. So what we tried to answer in this poster, in this project was, are we going to see the same effect, the same higher benefit with a combination of Ipi-PD1 compared to PD1 monotherapy after patients had already BRAF and MEK inhibitors, so in second line, but after blocking that BRAF mutation. So that was the concept of this project. So, of course, what we did was we did the international collaboration where we included all patients that had BRAF and MEK inhibitors, and then after that had either PD1 monotherapy or Ipi-PD1. So we have included 200 patients, and we can see in table 1 how they were, like the baseline characteristics in terms of some of them were, of course, imbalanced between the two groups. And as expected, patients were older in the PD1 group compared to Ipi-PD1. Also, patients in the Ipi-PD1 group, we have a high proportion of patients with brain metastases, and also patients with higher stages, so M1C, M1D. That's a normal selection bias that we clinicians have when we select patients for the two immunotherapy treatments. So that's expected. So then it comes to our results. Our endpoints were efficacy, objective response rate, progression-free survival, and overall survival, and also safety. So I'm going to start with efficacy. So what we saw is that if you compare, we can say that numerically, but not statistically significant, the combination of Ipi-PD1 was a little bit better across the three endpoints compared to PD1 monotherapy, but was minimal difference and definitely not statistically significant. So that's the first observation. And even if we compare with the results from the Checkmate 067 in these BRAF mutant patients, that minimal advantage is definitely smaller compared to that first line comparison. Then we did two types of analysis. One was within this the group of patients, of 200 patients, we have selected those who had an overall survival of 3 years or longer. So the patients that did very well in this setting. So after having BRAF/MEK inhibitors and then went on immunotherapy, independent of the treatment, as we saw that the treatment was not that different in terms of outcomes. So who are those patients and which clinical characteristics can identify those patients? And clearly you can see in figure 1D is a little bit what we would expect and what we see has good prognostic factors in other projects, but it's nice to see that it's still, we still see in this context, which is ECOG performance status of 0, so patients very fit, absence of liver metastases that we know in other studies and also studies from our group showing that liver metastases is a very poor predictor of poor outcomes with immunotherapy. So it's also true in this second line setting. And of course, normal LDH. So the combination of those three clinical factors, basically with those, we can predict quite well with the AUC of 0.84, those very good long survivors. And then we have also did a subgroup analysis. And we have done that for objective response rate, progression-free survival, and overall survival. I'm just presenting here overall survival. And basically what I want to highlight is two things. First, or three things. First, there is overall a trend towards a benefit with a combination, but this is not significant for any of the subgroups except, and you can see that here, for overall survival for patients with non-V600E mutations. So, for example, patients with V600K or other mutations. So that's quite interesting. Again, we have to interpret this data with caution because we are talking about retrospective cohort, smaller numbers when it comes to subgroup analysis, but it's an interesting observation. So another thing that I wanted to highlight, and that was consistent across objective response rate, PFS, and overall survival, is that even though we see that across all subgroups, we see a trend towards a benefit with the combination compared to PD-1 monotherapy, that is not true for basically two or three groups of patients. One is females. Another one is, which is not really here, but it's also in PFS and overall survival, in PFS and objective response rate, which are patients who had the immunotherapy right after the BRAF inhibitors, so with a shorter interval, and also patients with a lower staging, so stage 3 and resectable stage 3, M1A and M1B. So that was, and those three groups of patients, they tend, in fact, PD1, there was a trend towards benefit with PD1 monotherapy. And then the last thing was safety. So here in table 2, we're just presenting the high grade, so grade 3 or higher side effects from the immunotherapy. As expected, Ipilimumab more toxic than PD1 monotherapy. We have seen that in first line setting. We have seen that in all studies that we compare those two treatments. We don't have any new or unexpected toxicities, which is good. The most common were diarrhea and colitis and hepatitis, as expected. What we can say is that even though we have definitely a higher toxicity or higher proportion of patients with higher or high grade toxicity with the combination compared to PD1 monotherapy, in both groups, that proportion is lower compared to first line, if we look to the Checkmate 067 data. And that's probably because of a selection bias by us clinicians, because if someone had a very bad, if someone is not fit enough for second line, wouldn't probably have that treatment. So in conclusion, even though we see a numerical minimal benefit of the combination compared to PD1 monotherapy, this is not statistically significant, is minimal, and definitely smaller compared to the one we saw in Checkmate 067 in that specific group of BRAF-mutant patients. That's the first thing. Second thing is a combination of clinical factors. We can, at least in this, of course, retrospective study, we have to validate that, but we can predict quite well these long-term survivors. The third thing is that even though the majority of subgroups of patients tend to have a better outcome with a combination compared to PD1, that is not true for some of the subgroups of patients that I have highlighted. And finally, we see again, and as expected, more high-grade toxicities with the combination compared to PD1 monotherapy, but without unexpected toxicities, and is less than we saw in first-line setting because of patient selection. So that will be my summary of my presentation, of my poster at ESMO this year. Happy to answer any other question that you might have.